Good afternoon and good evening, everyone. My name is Dr. Onaiso, Regional Director for Asia at City Cancer Challenge Foundation. Let me welcome you all to the first discussion of Driving Quality Cancer Care in Asia series. It is great to see so many of our colleagues in cancer care across Asia joining us today. This new discussion series has come together thanks to our series hosts, the Asian National Cancer Center Alliance, National Cancer Center of Japan, Tata Memorial Hospital, and City Cancer Challenge Foundation. We would like to recognize discussion series partners, Chugai Pharmaceutical and Icon Group, for their support as we bring you a discussion each month in July, August, and September. Today, we have a very strong lineup of speakers who will be exploring the barriers and opportunities to implement and strengthen a multidisciplinary approach to cancer care in Asia. As we go through the discussion over the next hour and a half, I invite you to ask your questions to our panelists via the Q&A functions. We will be dedicating time at the end to answer your questions. Our moderator for today's session is Dr. Rolando Camacho, the Global Technical Lead at the City Cancer Challenge Foundation. Rolando has 25 years experience as a practicing oncologist and has worked and collaborated with the WHO, IAEA, and UICC. Now, may I hand over the session to Dr. Rolando Camacho, the moderator of the session. Dr. Rolando, the floor is yours.
Thank you, Hwang. Yes. Good afternoon for the people who is in this site. Good morning for most of the people who is attending to this series of discussion. This title is Driving Quality Cancer Care in Asia, which is a first experience of CCAN in trying to expand these learnings that we have been having from different cities. We have been working in the past 4 years, all the time trying to increase the quality of cancer care. And one of the most important ways to increase quality is based on the multidisciplinary approach. That's why we have been choosing this topic for this first seminar. Next one. Next one, please. We have been organizing this in close collaboration with the Asian National Cancer Centers Alliance, ANCCA, with National Cancer Center of Japan, and Tata Memorial Hospital, who is a partner of CCAN from years now. Next one. And we have the honor to have 4 great panelists, people with a large experience. I will speak of them in general because the 4 of them are people very well recognized in these topics that they are going to present. And the first one is the technical support needed for multidisciplinary approach. Many things has been saying about multidisciplinary approach. In my opinion, really, from my perspective, also, I see the most relevant things that how would we can give something to the patients. For me, is the right of the patient to receive the decision of the treatment or the proposal of the treatment taken by a multidisciplinary team, where many people can provide the opinions and not only one doctor. I have been in practice for many years, and in my opinion, that's something that the patient really deserves. Apart from that, Dr. Borras is going to give us an overview of the technical support for this approach. Borras is a scientific coordinator of the Spanish cancer strategy in general for the whole Spain, but also is the director of the cancer plan in Catalunya. And at the same time, I can tell you that I met him first when he was director of the Catalunian Cancer Institute in Barcelona. The second panelist will be Simon Hughes. He will represent ASCO. Sorry, because it's another extra word here. It's ASCO MCMC training, which is a very important tool for helping people to understand and to develop this multidisciplinary approach in the countries, in the cities, in the centers where they work. Dr. Hughes is an International Education Steering Committee Group Chair from the ASCO, American Society of Clinical Oncology. and also is a practicing doctor in oncology. The third one will be Dr. Pramesh, which is the director of the Tata Memorial Hospital. And he will go straight, apart from being a surgeon, a cancer surgeon with many years of experience also. But they have a very large network of cancer centers, and they have been working with this multidisciplinary approach for years, and having multidisciplinary groups working in the network of India. And he will talk about how to plan this work, and during the pandemic and after the pandemic. What is the vision after the pandemic? And the fourth one will be Dr. William Hwang, from director of the National Cancer Center in Singapore, which will talk about the challenge and experience of the MDT approach at that center. I will be the moderator. The next one, please. Next one, please. The main goals of this session, because the series is three series, so three sessions. So in this one, we will be focused in multidisciplinary approach in cancer care in the Asia region specifically, but of course having the experience in all over the world. And also it is important goal for this session to share experience and strengths collaboration across city cancer cities, partners, and regional experts. Not all the cities who are participating here are city cancer challenge cities, but some of them has been interested in the project, and probably in the future will be part of the project. Next one. So I want to pass the screen, not the floor, to our colleague Josep Borras, who is going to talk about technical support need for a multidisciplinary approach. The screen is yours, Dr. Borras.
Okay, thanks for the nice introduction, and thanks also for inviting me to this important session. I would like to talk about the multidisciplinary cancer care and some technical, let's say, evidence. No, so first, I think it's important always to remind, why do we need to worry about multidisciplinary cancer care, and what's the evidence and the organizational models involved, and some final comments as a global general conclusion. So first of all, there's some data that you need. This is the data about survival in rectal cancer in Spain some years ago. The main thing here is that there are regions in Spain that the 5-year survival for rectal cancer is 50%, and others that it's 65%. So this difference of 15 points, it's not due to the difference in health system, in the resources, it's due to the delivery of care. So the quality of the delivery and the organization of care, the specialization of cancer surgery in rectal cancer in different regions of Spain. So my main point in this presentation is that the delivery of care, how it's organized, matters, and matters a lot, and has consequences about on the outcomes of cancer care. And this is something that it was recognized some years ago by the European Union, saying that the outcomes could be improved if we apply what we know is effective, combining, and this is the important thing, organizational changes aimed at improving multidisciplinary teams with evidence-based therapy. So I think in cancer, it's also an organizational problem, a problem of how we organize cancer care. This also was recognized by a landmark work in the Institute of Medicine of the United States, that they say, well, one of the reasons for inadequate cancer care or inadequate care was also poorly organized delivery systems. And why? Why we need multidisciplinary care? Well, this is a slide from the European Oncology Nursing Society, but it's a nice representation of the complexity of all the process of or the cancer journey of a patient involving several specialists, several therapeutic and diagnostic approaches that really are required to offer a good quality cancer care in a way or another. So how we organize this, it's relevant. I think it's important also to say that there is evidence, not a lot of evidence, but there is evidence on multidisciplinary cancer care and evidence supporting the fact that multidisciplinary teams improve the outcomes, not only the process of care, but also the outcomes. Now, in this paper was published some years ago in British Medical Journal. It was a population-based approach based on population cancer registry data. And what essentially they did was to observe that in one region of Scotland, there was an intervention modifying the delivery of cancer care, introducing MDT, and the other not. And what they find was that when in the region that MDT was introduced was a reduction in the probability of death associated with breast cancer, and also a reduction in survival, an improvement in survival for all causes. The problem in multidisciplinary teams that it's relevant is that the multidisciplinary team change in this paper was not only change organizing a weekly MDT meeting. They also specialize professionals in surgery and pathology and medical oncology and radiation oncology. They introduce a specialized nurse. They discuss the evidence-based guidelines, so they agree on a protocol, and they audit the clinical activity. So many changes take place at the same time when we change towards an MDT meeting. And this is one of the problems to assess what the improvement in the outcomes could be observed from the multidisciplinary team's introduction in one hospital. So I think it's important to realize that this is a change in the organization of care. And while they say that the multidisciplinary team was associated with a better survival and with the removal of poorly performing hospitals and reduction of variability among hospitals, which is also a very important and relevant outcome. So there are other reviews of about multidisciplinary team. This is an Australian one that clearly shows that potential benefits of multidisciplinary teams are the care are more likely to be evidence-based, all treatments are considered, referral pathways are improved, and for the patients, obviously, increasing survival and increasing satisfaction, and also increasing access to information. We did also a review some years ago in the framework of a global action at the European level, and part of the background documents were this paper that was published some years ago, that essentially we found that MDTs were associated with better clinical and process outcomes in several tumor sites, changes in the clinical decision-making, and also organizational components were more relevant, like shortened time from diagnosis to treatment or other improvements. So I think that there's also an Institute of Medicine paper supporting this. However, we need also to discuss, when we are talking about tumor boards or we are talking about multidisciplinary, what's the component? So I think in general, there is broad general consensus that there are core members, like the people involved, colleagues involved in diagnosis and treatment. Also case nurses or patient navigator, depending on the countries, the definition and the role could be slightly different. But I think the diagnostic and the therapeutic involved clinicians are relevant for discussion. There are other consultants, depending on the cases, about psycho-oncology, rehabilitation, pharmacy, palliative care. It's highly relevant, and it's, at least in Europe, it's one of the major problems, the administrative support and the IT system support for multidisciplinary care, and also the role of the clinical leader that should prepare the discussion and encourage all the clinicians to take part in the discussion and make comments that are respectful to the other specialists. So what are the usual problems? Well, you find listed in in the question that was submitted at the beginning of this session, no? The protected time for tumor board meeting, lack of administrative support, the potential role of patient navigator or case manager, the discussion that in Europe at least is quite important. Some places that to present all cases are only the difficult ones. Our position in general is to mention all cases, but only discuss the difficult ones, because it's better, it's good that everybody knows how many patients are involved in that week in the multidisciplinary discussions. The support role of the heads of the clinical services involved, which is a problem in some cases, the continuity of the health professionals, and that this is very important, the participant specialist in the tumor board should be also the clinician responsible for applying the treatments or applying the decision. This has been recognized at the European level in the cancer strategy that it's recently implemented based on the previous work that was developed by the European Joint Actions. And it's important for us because it frames the model of organization of cancer care in Europe based on this consensus. Also, we develop a policy statement on multidisciplinary cancer care with all the scientific societies and patients organization at European level. And well, this is the list of the organizations, and also we define the cancer, the multidisciplinary teams, essentially based on evidence with all stages of the process, so not only the diagnostic or the initial treatment, but also I think many multidisciplinary teams are expanded on the follow-up, and encouraging the patients to take an active role. So this could be applied. This is data from Belgium. So from 70 to 94 of the patients are submitted and reviewed in multidisciplinary teams in Belgium. So this is feasible to do. And also, I think it's important also to recognize, and that editorial was highly interesting for me, because what they were saying, so do we need more evidence? So I think they say, well, we need to refine and discuss how we need to implement these multidisciplinary teams and consider them as an intervention in its own right. So I think it's important because we discuss a lot of the evidence. I think it's important to discuss all the evidence, but also we need to discuss how to implement and how to organize cancer care at local level in order to make feasible to apply. So as a concluding comments, and I hope I more or less on time, evidence on the improvement of clinical outcomes associated with MDT are weak, but consistent. The implementation usually takes place with other organizational changes in cancer care, making difficult to assess the individual impact on cancer outcomes. But I think it's important because probably it's all the changes that has the consequence of improving the outcomes. MDTs implies a paradigm shift from disease management to patient-centered approach, because we take into account more psychosocial aspects, also the opinion or preferences of the patients for a specific treatment. I think the right place is multidisciplinary team for discussing this, and some cases maybe ask the patient. Increasingly more attention is paid to psychosocial aspects and quality of life and patient rights and survivorship, and the new dimensions add complexity to cancer service organization. We need to recognize this, that it's more complex, but also bring opportunities to improve the quality, making cancer care more tailored to individual needs and more effective in addressing the patient needs and improving the outcomes. So thank you very much, and I will be more than happy to answer any questions.
Thank you very much, Dr. Borras. I think that this is an important issue that you cover now. It's the next one, please. Okay. To recognize that we need to have more evidence, of course, but with the one that you have been showing, I think that no one can say it's not needed. We have to implement that. The way to do that is more difficult, it's more complex, but again, the patients deserve that. So thank you very much for the presentation. Very, very useful. Then now, to train the people, to motivate the people to implement this type of approach, you need some kind of tools, and training is very important. One of the most successful one I have seen one of the best structure one I have seen, and it's very popular worldwide in this moment, is the ASCO MCMC training for a multidisciplinary approach. That's the topic that Simon Hughes will do now. So the screen is yours, Simon.
Thanks, Fernando. Good evening, everyone, and thank you for inviting me to speak at this meeting on focusing on multidisciplinary approach to cancer care. I'm a clinical oncologist and I'm based in London, UK, and I specialise in the management of urological cancers, but I spend about half of my time in medical education. And one of my education roles is chairing the International Education Steering Group at ASCO and working with the excellent ASCO team. So I'm going to give you a brief overview of ASCO and the international courses we run, our different models for collaboration with our international partners, and then also what we do to assess the outcome of our interventions. So ASCO is the largest professional oncology society in the world. And as you can see from this map depicting where our colleagues and members work, we have global coverage. We've got members in over 150 different countries. And it's the ASCO mission to conquer cancer through research, education, and promotion of the highest quality and equitable patient care. And that really fits perfectly with the topic of our discussion today on multidisciplinary care. So ASCO is not just US centric. A third of the membership is outside the US. We also have international representation on committees, and I'm probably a very good example. I'm a British oncologist and I'm chairing the International Education Steering Group. And next year, Dr. Barrios from Brazil will be taking over my role. So they're very keen on international collaboration. There's also a drive now to ensure that there's international relevance and perspectives to the education content produced by ASCO. So if anyone's been looking at ASCO education resources in the past and now, you'll see there's a different theme, and so it's going to be more relevant to the whole of the ASCO membership rather than just the US, which may have been a criticism in the past. ASCO also have discounted membership and resources for clinicians in low to middle income countries. And something I always tell my trainees is that ASCO membership for trainee doctors is free. And that gives them access to the oncology journals, and they can also apply to other grants and educational resources as a result of being a member. So these are the three mission pillars for ASCO: so quality, research, and education. And education is really where we focus on the skills, training, mentorship, and leadership. And this is where we're taking a lead in multidisciplinary training, although there's also an element in our quality theme as well. So ASCO collaborates with societies and institutions around the world to bring education opportunities to learners in the areas of multidisciplinary management of common tumor types, clinical research, palliative care, and also education for primary healthcare workers. Often when we receive a proposal, we combine two or more of these elements together. So we may have a multidisciplinary management meeting on, say, prostate cancer, and we'll combine that also with a palliative care module as well. And in such programs as well, we've also got other developmental themes of professional skills and looking at improving and developing functional tumor boards or multidisciplinary meetings. So this slide outlines the process for developing a collaborative education program. And I think the highlight here is collaborative. So firstly, the Oncology Society or institution will submit an application to the ASCO international team. And if successful, then a multidisciplinary expert team is assembled, which includes local experts from the same institution or country, or even neighbouring countries. And then a needs assessment is performed and the programme is developed in partnership with the applicants. And then once the courses are delivered, we then seek feedback immediately and also 12 months after completing the course to assess our impact and also to learn what things worked and what things we could improve on in future. So one of the themes we have are the multidisciplinary cancer management courses. That's the MCMC that you saw in the title. And the goal of these courses is to demonstrate how nuanced multidisciplinary decision-making takes place in the management of common cancer types. So with the participation of all healthcare members in the process. So it's really demonstrating that when you get the whole team together, you get a more powerful outcome. And the important thing here is the nuance as well. There's slight differences in patient presentations, which will actually impact on the final treatment decision. It's not all protocolized. You need to bring everyone's experience to the table. And when we run these courses, we also use the latest learning science principles as well to optimize the learning experience. So worked examples, contrasting cases, interactive discussions. So it's a very active learning rather than just sitting there being spoon-fed. And then when we run a course, we've got some sort of overarching learning objectives. So on completion of the course, we want our learners to be able to better understand the different roles and responsibilities within an oncology care team. And through this, we aim to improve communication and functioning of the team. We also aim to improve the learner's knowledge foundation, making diagnosis and treatment of common cancers better, and by further developing their skill set. And all this is done in a culturally and environmentally relevant manner. And this is an example of assessing our impacts. This was a course run in the Ivory Coast. And what we looked at was a year after running the course, 45% of respondents were more involved in tumor balls, and 84% indicated implementing a change in their practice due to something they learned during the course. This is just an example. We have far more in-depth questionnaires to assess this. This is just a summary figure. So we've looked at our multidisciplinary cancer management courses, but another avenue we can go down is the local tumor board development programs. And these are developed in a similarly collaborative manner. And the goal here, though, is to provide hands-on training for setting up, assessing and evaluating local tumor boards and how they function within an organization. And this is just an example of the panel for Ascension. So you can see that you've got a very good team working there together. And that's the ASCO international team, as well as a local team in Ascension, Paraguay. So these programs started in 2004. We've currently held 54 of them in 32 different countries. You can see the span across here. So there is a heavy representation here from Asia, also Africa and South America. And whilst COVID has probably changed our delivery model, we're now doing a lot more face-to-face and online. I think the multidisciplinary message is always the same. And I think, to quote Oliver Sartor and John Fitzpatrick, the real key is not the specialist, but rather the circumstance. Each patient receiving the best care at the most opportune time. Good coordination between the various specialists involved in the patient's care is clearly necessary for optimal results. Thank you.
Thank you, Simon. Can I have the next slide? I think that is you can see that I was saying. You can see how it was presented in this great way that he did, and also I take the opportunity to thank ASCO, because most of the city that we have working with in CCAN has already been able to implement MCMC. You see you have been seeing the picture of Yangon, Asunción, but also was in Cali, and it's planned for Kumasi, Kigali, Tbilisi, Porto Alegre. So it's a large number of cities in CCAN has been able to have this possibility of this opportunity. So now it's implementation science. It's the part that I like very much, which is I think that one of the person that is more relevant in this area of implementation is Dr. Pramesh, and he's going to speak about the experience in Tata Memorial Hospital, how it happened. Probably he will refer that before too, but especially during the COVID and after the COVID, what is in mind, how they can plan to do that in the next years, in the next time. Dr. Pramesh, the screen is yours.
Thank you, Rolando, and take this opportunity to thank Rolando, Hwang, and the entire CCAN team for this great opportunity to be part of this fascinating session, right? So I work at the Tata Memorial Hospital in Mumbai. I am a thoracic surgeon, but I'm also the director of the hospital. And I also coordinate a large network of cancer centers in India called the National Cancer Grid. So I think we heard a bit about why MDTs from that excellent initial presentation by Dr. Borras. But I'll just like to emphasize the importance of this by the study that was done a few years back in the United States, where they compared recommendations made by urologists and by radiation oncologists for the treatment of localized prostate cancer. So hypothetical situations were given to over 1,000 oncologists treating prostate cancer. And one of the situations given was this: a 65-year-old gentleman with good health, no extra prostatic spread. And these 1,000 plus oncologists were asked what would be the primary treatment that they would recommend. Out of these 1,000 and odd oncologists, over 500 were urologists and slightly more radiation oncologists who were polled. And these were the results. So as you can see, the figure here gives you the Gleason score and here the PSA level, and various hypothetical situations with the same clinical picture were posed to them. And what you can see is, for example, with someone with a Gleason score of 7 and a PSA of 10 to 20, 71% of the urologists suggested that surgery would be best, whereas 95% of the radiation oncologists very unsurprisingly said radiation would be best, and so on. With 8 and 5, it goes on to 72% of surgeons saying surgery and 94% of radiation oncologists recommending radiation therapy. So what does a patient have to do when you're confronted with diverse opinions like this? And this is where the importance of MDTs come. And again, you heard from both Dr. Borras and Simon about the importance of multidisciplinary care, which is clearly the hallmark of high quality cancer management. And we use this very frequently as a metric of how well a cancer center or a hospital treating cancer is being rated. The adherence to multidisciplinary care is one of the plus points that a cancer center can have. So we all realize that it's a very crucial element of cancer care. These need to be regularly scheduled. The intent being that prospective individual cancer patients have the benefit of a multidisciplinary opinion, and which then makes recommendations on what the best management should be. And increasingly, with inequity and diversity coming into the forefront of cancer care, we do realize that regardless of someone's socioeconomic or geographic location, they should have the opportunity to have their case reviewed in an MDT. Something that's not very well recognized, but are extremely important functions of MDTs, these are secondary and not primary to the issue of patient care, are these. It's actually a great forum for continuing education for health professionals, and I'll describe that a bit more later in my talk. Patient care quality improvement activities and practice audits can be made as a result of these, and there are various examples of how these have happened. These are also an opportunity to develop standardized patient management protocols. So what might be evidence-based practice in the West may not actually be applicable in low and middle income countries, and MDTs offer you the opportunity to distinguish between these two. And finally, it enables us to identify gaps in evidence and to look at research as an opportunity and to encourage participation in clinical trials. So we have 3 different formats of multidisciplinary care at Tata Memorial. And here, while I'll focus primarily on the first, which is the clinical multidisciplinary cancer care meetings, which are held between 2 to 4 times a week per disease site. So for example, in common cancers like breast and oral cancers, these are held 4 to 5 times a week, practically on every working day. Whereas with some of the rarer cancers like sarcomas and neurological malignancies, these are held twice a week. In addition to these, I'll just very briefly describe the disease management group meeting. So the structure at Tata Memorial is divided into 11 different disease management groups. So for example, the breast cancer group has a separate group, the thoracic group is separate, the gastrointestinal group is separate, and so on. And we have between 1 and 4 meetings per month to decide more on policy and evidence-based protocols. And finally, there's a hospital-wide multidisciplinary meeting, which is conducted once a week, where the best possible evidence is presented, mortality and morbidity is audited, and so on. And all members are encouraged to contribute. I will come back to this last point in a minute. So we started clinical MDTs at Tata Memorial in 1978. These started primarily with lymphomas, where the medical and the radiation oncologists took the lead in creating a multidisciplinary group which discussed every patient with lymphoma being treated at the hospital. This was then fairly quickly adopted by the urology and the gynecological disease management groups. And this happened primarily because the leaders of these two groups had trained in the United States, and when they came back to Tata Memorial, they implemented these policies. But over a period of the next decade, these were formally adopted in all the disease management groups at Tata. A couple of important points, which I think is crucial to the success or otherwise of MDTs, and I think Dr. Borras mentioned this as well. There needs to be equal participation in decisions, and here we are very, very democratic in the way we approach individual patient decisions. The so-called non-clinical departments like pathology and radiology are actually far more clinical than in many other centers at our own hospital. And they, in fact, participate very equally along with the medical, the surgical, and the radiation oncologists in various aspects of care. And I'm extremely proud that in our own disease management group of thoracic cancers, I could very well allow my radiologist to make clinical decisions because of sheer practice of being part of these disease management groups. They have an extremely good idea of how clinicians think and make decisions on. And this is fundamental to whether your MDT is likely to be successful or not. The second most important aspect I would stress is administrative support for protective time. And right from the from the 80s of the last century, the administration at our hospital has been very, very protective about the time that clinicians and radiologists and pathologists and the various the constituent members of the MDT have as far as participating in the MDT go. So our practice is that all patients would have an MDT at 2 points. First, before they start the initial treatment, and at any subsequent decision point when there is likely to be a change in treatment that is being done. Now, I do realize that this is not practical in many situations, and you could adopt a more selective approach like what Dr. Borras mentioned, that only the complicated patients would get discussed. But this is something that you would need to decide as you start your MDTs. And not surprisingly, we actually helped, these MDTs actually helped us towards the subsequent development of resource stratified evidence-based management guidelines, which have been in place at our hospital since 2003. So this would be the typical constitution of an MDT at Tata: surgical oncologist, medical oncologist, radiation and palliative care. In addition, radiologists, molecular imaging radiologists, pathologists. For specific areas like thoracic, you would have a pulmonary physician, and for gastrointestinal, you would have a medical gastroenterologist, a physiotherapist, and a nurse. But the core elements of an MDT would be the top 5, which would be the surgical, medical, and radiation oncologist, palliative care, and the radiologist. You could get in the remaining part and on a as per need basis. But if you have the resources to do so, getting the entire team in place is ideal. So the benefits of an MDT have already been described. They do result in real-time opinions from different specialists. I quite like the fact that we all discuss together rather than this being done sequentially. It promotes that all aspects of diagnosis, staging, and comorbidities are taken into account before deciding on a particular treatment plan for an individual patient. And very often, as experts in our own specialties like surgery or medical oncology, we tend to forget some of the other aspects, and it's good to have the team remind you of other comorbidities and so on. And I honestly think that this is more likely to be evidence-based, based on the fact that you have a number of experts in their own specialties contributing towards the care. And I think most importantly, all of this contribute towards making the overall management patient-centric. So this is a typical MDT at the Tata Memorial. You have the head and neck group here, the surgeons, the radiologist, the medical oncologist, the pathologist, and the palliative care physician, all discussing a patient's imaging before treatment is decided. So we all know that we had to make some changes during the COVID-19 pandemic. So we had to rapidly adapt it both for the safety of our patients as well as our healthcare workers. So initially, we reacted by restricting the MDTs to more complex clinical situations and keeping the straightforward decisions out of it. And we also partly switched to the virtual mode in order to ensure physical distancing. But also, we had to adapt protocols and management plans because of COVID-19. We came up with shorter durations of radiation, for example, triaging between patients who required early surgery versus those who could afford to wait for some time. And again, this demonstrated the strength of MDTs, because rather than be restricted by a single perspective, we had the benefit of multiple experts opining on their care. So we've tried to scale up MDTs beyond Tata Memorial. We take our responsibility as the premier cancer center in the country very seriously. This is one of the ASCO MCMCs, which Simon just mentioned. This was held 3 years back at Tata Memorial. The last one, unfortunately, had to be converted to the virtual format because of the pandemic, but we will be holding another one in the next couple of years. So this is the National Cancer Grid, and much before COVID started, we initiated a process of virtual tumor boards, primarily because if you look at some of these centers which are spread across the length and breadth of the country, there are remote areas where they lack the bandwidth to have MDTs of their own. So we started doing virtual tumor boards almost 5 years back. We've held over 800 virtual tumor boards so far. We average between 2 and 3 virtual tumor boards every week, and these are disease specific, where we have anywhere from 25 to 40 of the cancer centers which are part of the NCG contributing towards the opinions, and anywhere from 110 to 150 physicians from different parts of the country participating in these virtual tumor boards. So when we actually needed to adapt to the COVID pandemic, we found this a very simple transition because we've been doing this for 5 years now. So I'll skip this and go straight to the summary. We do realize the importance of multidisciplinary teams. They clearly improve processes, as well as some data to suggest that they improve patient outcomes as well. And as the pandemic has shown us, we need to be adaptable and flexible. It's not a one size fits all. We've again learned from the pandemic that virtual solutions are possible. But to me, possibly the most important benefit of a multidisciplinary approach would be that it promotes evidence-based medicine. And one of the key elements of a successful MDT approach is that it needs to be democratic, and communication between the members of the disease management group and the MDT is crucial for the success of an MDT. So I'll stop with this for now, and happy to share questions during the discussion section. Thank you.
Thank you, Dr. Pramesh. I think that's a very important topic. We can share the next slide. I think that this is an important issue that sometimes you cannot do as a classic one. There's not only one pattern to do a multidisciplinary team, but also for multidisciplinary approach. For multidisciplinary approach, it's like you have rules. For multidisciplinary team, this is more a way to implement according to the possibility that you have. That's excellent, and that's why we ask Dr. William Hwang to present also in this session the challenge, but in the different kind of center. It's a National Cancer Center of Singapore, and also have the experience of how they have been dealing with that. The screen is yours, Dr. William.
Thanks, Sir Orlando. Well, good morning, good afternoon, and good evening to everyone. It's really my pleasure and privilege to be able to share with this prestigious panel on our experience with a multidisciplinary team approach at the National Cancer Center Singapore. The National Cancer Center Singapore has a vision to be a global leading cancer center by offering our patients hope by providing the best care, best people, and best research. Today, I'll focus on 2 topics: the importance of multidisciplinary teams, which many of my preceding speakers have spoken on. But I'll focus a little bit more on how to successfully implement MDTs. Firstly, on the importance of the teams. As has been mentioned, it allows people to focus on the specialized areas while tapping on the broader expertise of a broader community. So it allows us to all focus on, because cancer science has progressed at such rapid pace, it's impossible for all of us to be familiar with all aspects of cancer. So we need to focus, but at the same time, rely on our colleagues in order to broaden the expertise that we deliver for patients. And it's not just involving multiple specialties, people from surgery and physicians, radiation oncologists, but also multiple job types like doctors, nurses, allied health, and so on. and also multiple institutions, which I'll touch on a little bit on later. And also it allows, as has been mentioned by my preceding speakers, allows us to be able to have a bit more of evidence-based medicine as opposed to eminence-based medicine, basically so that any decision is based on what is best for the patient, based on international as well as solid science, international literature and solid science, and not just based on what the most prominent physician has said. And adopting this approach has allowed us to do well in our service as well. We were the first institution in Singapore to get the Singapore Service Medallion, and also listed on Newsweek as one of the world's best hospitals. This is our National Cancer Center. It's just a 6-story building, which is a purely outpatient center that is linked to the Singapore General Hospital that has over 1,600 beds. This approach for multidisciplinary teams has allowed us to also improve in terms of patients definitely recommending our service, such that patients over 93% currently say that they would definitely recommend our cancer center to other people. So in terms of multidisciplinary boards, we have had over 20 different tumor boards for different tumor types. Attendance by physician, surgeon, radiation oncologist, palliative care, pathologist, pharmacists, nursing, physiotherapists, occupational therapists, social workers, and researchers. Allows us for crafting of standard pathways and protocols, allows us for recruitment of patients on the clinical trials. We also have a separate molecular tumor board. And at the tumor boards, we have interface with our electronic medical records so that decisions are immediately documented and recorded in the EMR. We sometimes use RedCap as well as a data entry format for research. But today I would like to talk a little bit about going beyond the traditional teams when we talk about multidisciplinary teams. And this has to do with how we successfully implement multidisciplinary teams. We are talking about cross-functional teams, and I'll talk about 2 entities called STDCs and CSLDs here. And the reason for it is such. Because even in a specialized group area, for example, head and neck surgery, you have your head and neck general surgeons, you have your ENT surgeons, and then you have your oromaxillofacial surgeons. And they may have different protocols in different institutions and sometimes compete for cases. Even in other forms of surgery, for example, in liver surgery, for example, you have your surgical oncologist, and then you have your general surgeon. In thoracic surgery, we have general surgeons who specialize in thoracic surgery, and we have cardiothoracic surgeons who are brought up on the cardiothoracic track as well. So how do we bridge these teams across multiple departments and multiple institutions? So in this regard, we're fortunate that the Cancer Center does not function on its own. It's really part of a healthcare cluster called SingHealth. And in that regard, we interact with multiple institutions within our campus, including the General Hospital, the Heart Center, the Eye Center, the Dental Center, which is somewhere not on this chart, as well as the Duke NUS Medical School. So it allows us to be able to set practice to benefit patients best in terms of quality, access, and safety, for common resource management to tap on the collective strength of the campus. And we already have many things in place and several things that are works in progress in this approach. And beyond this campus, we have also other institutions within the SingHealth cluster that we can also tap on in terms of tapping on mutual expertise. But again, also easier said than done. So we created an entity called SingHealth Duke NUS Disease Centers. These are virtual centers that provide a strategic model of care so that patient focus, they will bring together multiple teams, enabling professionals from different backgrounds to work closely together, developing evidence-based protocols for training, education, pooling expertise and databases to measure outcomes, to foster interprofessional collaboration and learning. And in this integrated network of cancer care and research, patients with suspicious masses, for example, may present to the polyclinic. They may subsequently come to the cancer center. They may go to the general hospital for their scan or the heart center for pre-op tests. And then we work in this entire journey together as one entity within the different disease specialty groups that you can see here. And some of them are not cancer related. Some of them have to do with other specialties. And this is because we wanted to break down silos between institutions, break down silos between departments, break down silos between job roles. This is an example, for example, in the breast cancer service line, everyone as in part of this is really part of the equation. And another example would be lymphoma. Lymphoma, for example, you have hematologists, you have medical oncologists, you have radiation oncologists, and different people coming on board, and different pathologists from different institutions. We also bring them together, including research and education as well. So this allows us to coordinate cancer services across the SingHealth cluster, whether in the polyclinic, pathology, and so on, to develop cluster-wide strategies in conjunction with maybe population health, for example, and to have standardized reporting and wait times, to develop common guidelines, protocols, and pathways across all our institutions in order to be a leadership in cancer survival, incorporating the rehab and long-term survivorship as well, to provide coordinated, timely, accessible care with palliative care and right siting of patients. This provides an entire continuum of cancer care to address prevention, diagnosis, treatment, and survivorship. Now, this is all easier said than done when you bring together multiple teams. People don't always work together and sometimes at odds with one another. So one of the key in this is central HR management. So we all have central employment. We are not employed just by our institutions, we're employed by the cluster and report to the cluster of institutions. We also have metrics appraisals. Instead of just reporting to your department HOD, you also report to everyone else within that entire matrix, so that and with a 360 degree appraisal. And remuneration is not just based on your personal output pertaining to your surgeries and your patients, but also what you do together with everyone else. And in this regard, I think leadership is particularly important. Firstly, to recognize the challenges, to recognize that yes, people have the needs for their silos and otherwise, to engage people and to engage in change management. And in change management, many people in the administrative track will be familiar with Kotter's philosophy in change management. And there are many forms of ways in which you can embark on change management. Firstly, the awareness of need for change, a desire to participate and support the change, knowledge on how to change, ability to change it, and most importantly, reinforcement to continue to sustain the change. And this is once again a reiteration of what I spoke about, basically the importance of multidisciplinary teams. And in order to extend multidisciplinary teams across different groups, across different institutions, it is important to develop cross-functional teams, HR management, and leadership. And with that, we're really looking forward to our new National Cancer Center, which we hope to move in next year, which will be a 28-story building. And I still have only 20 seconds left. So thank you very much for your time.
Thank you. Thank you very much, Dr. William John. So next slide, please. I think this is a summary of our presentations now, but we have also the view from the field, voices from the field. The first one who's going to speak is Dr. Nur Aizat. She's a consultant breast surgeon from the University of Malaya Medical Center. The screen is yours for 3 minutes, please.
Hello, everybody. Good afternoon, good morning, and good evening. Nice to meet everybody, and wonderful talks I think we've heard from all the speakers. I guess a little bit of sharing in what's happening around in Malaysia at least, and more specific to my hospital, University Malaya Medical Center. We're not a cancer center, but we have a lot of academicians who actually practice cancer care. So we have something like 20 units of different specialities, ranging from pediatric oncology, breast surgery, breast oncology, head and neck, orthopedics, and everything else. So, well, a bit of sharing on how to successfully implement multidisciplinary team meetings. Maybe I can share a little bit of our experience from the breast cancer group. We have had MDTs from 2003. That was really because we felt there was a very great need to improve the timeliness of the diagnosis of our patients and how we can coordinate better with the pathologists. So over the years, we have now come to 2021. For the breast team, we have 2 routine MDTs every week. So we have a diagnostic MDT that we run with the radiologists and pathologists and breast surgeons. So I have to say the surgeons took the lead because we are the ones managing the patient as the primary care team. We are seeing patients, we have to be the ones who actually coordinate care really for the patients. And I think the administrative support, I think all of you mentioned, is extremely important. In 2005, we managed to get a resource center for our breast cancer team. And we have breast care nurses who actually manage the administrative aspects of the MDT. So we have people organizing lists every week. And it's, again, a very good training tool, I think, for our medical officers who are in the Master of Surgery program, as well as our fellows as well. Just to share, I think over the years, as I told you, we have now 2. So we've got one with the diagnosis and the other one is with the oncologist, basically to discuss neoadjuvant as well as adjuvant therapies around patients that we have diagnosed with breast cancer. And we have also got palliative care MDTs that we do every Monday, as well as special MDTs for example, difficult cases like breast cancer in pregnancy. And we sometimes have joint meetings with our gynae oncologists when we have, multi-cancer in a single patient type of settings. So I have to say it is very good that we have MDTs because we actually have the people and the capacity in terms of specialists and consultants from the different fields. But I can feel for my colleagues around the country where some of them are working in maybe the only specialists in that hospital with no support from oncologists and so forth. So I really appreciate all the talks that you have given because you have sort of structured how, how you can actually improve, not just from a single hospital, you're able to even reach out to the other hospitals around the region. And I hope that what we're doing with the Greater Petaling City Cancer Challenge, we can actually improve that network around the city at least to improve capacity, at least to ensure that people are following guidelines. We do have a clinical practice guideline that we have updated in 2019 was the latest one. So I think there are a lot of things that I think we're looking forward to doing with the City Cancer Challenge group. And I think the other thing I wanted to mention was, yes, I think, having MDTs really help us in a very busy public hospital because, at the end of the day, when you want to deliver patient-centered care, where your patient is confident about treatments, communicated by very young junior staff members, you need to have good decisions already made before that. So that confidence in applying whatever recommended therapies to the patient actually has great. I'm sorry, that was my son. I'm sorry, I'm at home. You can hear a cat, but it's not really a cat. Yeah, so really, I think having a confident young personnel who is confident about communicating the recommended treatments to the patients is extremely important, I think, for the uptake and adherence to that therapy. So I think that's all from me. I think my 3 minutes is up.
Thank you very much. Yes, 4 minutes. Thank you very much. The next one from the field is going to be Dr. Bayar. Dr. Bayar is from the Deputy Director of the National Cancer Center in Mongolia. The screen is yours, Dr. Bayar.
Okay, thank you, Dr. Alanda. Hello, everyone. Good evening. First of all, thank you very much for giving the opportunity to say a few words, to make voices from the field. Field is NCC, Mongolia. And very shortly, I will try. So the NCC, we conduct the tumor boards for common cancer sites, for mature cancer sites, just like a liver, gastric, esophagus, by different specialists to work together and sharing clinical decisions in cancer care. But however, I have to admit that we do not well organize it weekly tumor boards. I mean, the tumor boards are organized rare for only complicated and challenging cases. But also we do some virtual tumor boards with different international organizations, but it's also not so often, once in every 3 months in this way. And very shortly, I would say we are in the beginning of conducting and developing the MDT. How we see the advantage? We believe that MDT is the best way to provide the complex care, because the cancer treatment is complex. It's about improvement health outcomes and also the satisfaction for patients and the families. Because of MDT, multidisciplinary team approach, the communication is better. I mean the better communication between the specialists, between the doctors, and better understanding each other and the case. And it's very important when all health providers talk in one language. It's much easier and clear to understand for the patient, for families. And it means the most advantage of MDT is the communication, understanding, and collaboration with the patient and families. It's very important to achieve a good result in treatment and to have high quality of treatment. We need very good understanding between the professionals and patients and family and work all together. And another advantage is the more efficient use of resources, particularly when your resources are limited, a shortage of supply, facilities, and professionals. And that's the challenges for NCCJ Mongolia. Our challenge, it requires a very well organizational job. It requires well led. For this purpose, we need competent health managers, clinical leaders, and we have good doctors, we have good professionals, but they need to be particularly trained in organization of MDT. We need specialists who train it, particularly, especially on this job to conducting, organizing the tumor boards, MDT, and who can improve our teamwork. Again, communication, understanding within the organization, and it means for the patients and for everyone. Okay, thank you for your attention.
Thank you very much. Thank you very much, Dr. Bayar. I think that you have raised a very important topic. It's important to say frankly what is ongoing, and the most important thing to identify the need, the leaders to want to work. That's important, and train the people. Excellent. So now we have a few minutes for questions. I have many questions, but some of the questions has been answered already by the speakers. So I will ask first Dr. Borras. They will ask, some people were asking the difference between tumor boards or multidisciplinary team meetings and the multidisciplinary units for cancer care.
Well, thank you for the question. Yeah, I think that it's important to consider the implementation of multidisciplinary teams as a process. So usually you begin with tumor boards that meet voluntarily because people feel that they need to do that. Then more formally organized, so inviting all the specialists and organizing the meeting and thinking about what kind of patients should be presented. I think it's important, the next step is to present all the patients, so to protect time for doing meetings. And then I think, at least it's our conception here, or it's our approach here, although it's a matter of, sometimes of definitions, that the multidisciplinary teams units are, let's say, disease-focused groups that could manage the process or the pathway of the patient in the hospital or even between hospitals. So I think multidisciplinary units are one step forward in terms of organizing, for instance, the access to radiology, to pathology, and to surgery, or to any of the resources of the hospital, with a perspective focused on the organization of care around one pathology, one tumor site. I think it's tumor boards for me are more a coordination of the process of care and the clinical decision making among all the professionals involved. Tumor units, it's let's say a further development in the organization of care with capacity of management of the process.
Thank you, Dr. Borras. I have another question for Dr. Simon. How does the institutions apply for receiving an ASCO MCMC? How is the process? Is difficult? How is it?
So it's quite a simple process. There's an online application which gets reviewed by the panel that I chair. And what you basically need is a letter of recommendation from the society or institute that's applying, because you want to ensure there's engagement, bit of information about the organization, what course you'd like to host, what format, location. Admittedly, everything's online at the moment. Then very practical things like the dates, language, target audience. Obviously, with target audience, we're looking to make sure it's a multidisciplinary audience and not just focus on, say, pathologists or radiologists. Attendance numbers and from where. I guess a good example is we ran a course in French in the Ivory Coast, but we invited other Francophone countries from West Africa there because we wanted to get the maximum impact for the course. And then what do you think are going to be barriers to attendance? And then really what the most essential thing is that you want people to learn when they come out of the course. Other learning outcomes, whether you need funding. And then we asked for a draft program, because this isn't a you go to ASCO, we'd like a program on this, ASCO delivers. It's a collaborative, iterative process. So we asked the people applying to come up with a suggested program, and then we work with them to develop it. So that's really the process. Then it's a few online meetings to develop the course if it passes the criteria for hosting it, and then off we go.
Thank you, Simon. Dr. Pramesh, there are many questions for you, but I will try to distribute with the rest of the people too. One of them is that when you have many patients and sometimes not many staff, how do you deal with that? How you prepare and you organize? Because also it's something that Dr. Baya was mentioning.
Yeah, that's a great question, and I did answer that in the chat of the Q&A. But for the benefit of others, I'll repeat that. It is often a struggle where you don't have adequate number of oncologists and other specialists to be part of the MDT. What I would suggest is that they start off with at least the complex clinical situations getting discussed in an MDT. So therefore, you're limiting the amount of time that you need to spend. And then as and when you get more experts, expand it to more. So there are several ways of skinning a cat. What we described at Tata Memorial is not the only way. You could very well limit it to only the complex situations and then go ahead with that. But I do understand the pressures on time that physicians in low and middle income countries face. And supportive administration is always helpful. The leadership putting its weight between the importance of an MDT. So these are what I would suggest.
Thank you. Dr. William, there is a question that I think that you will have the best option for answering. And it is, should we have rules, regulations for referral from one center to a bigger center to a more complex center? Should be something like that, written regulations?
Many of the referrals that we have are based on either prior agreements, as well as some of them are ad hoc type of referrals. And really the decision to present the case at the tumor board is really based on the receiving physician, because sometimes it's a very complex case. Sometimes it's fairly straightforward, but some cases that we take on can be quite complex. I'm not really sure if I managed to answer your question in that regard, but yeah.
Yes, it's normally in some places, like you don't have multidisciplinary team regulation to establish the multidisciplinary team in the hospital or in the city or in the country, but also you don't have a clear definition of which patient has to be referred, in which stage, depending of the stage, depending of the cancer site. Sometimes you have more developed centers with higher technology and some small center who can do many things. So it should be written referral system, I will say regulations should be approved by the Ministry of Health. Should the Ministry of Health care about this, or the network of cancer centers should care about this? Who should be treated here? Who should be referred? Because also sometimes you have to give that information, instructions to the people who is in that small center, but also in the higher center, because if they treat everything, they might not be managed easy to manage for those specific cases that they have the resource to manage that the others don't have. So the question is, should it be clearly written, agreements, regulations? That's the question. I think that you answered.
I think in a sense it's difficult to set it into a definite regulation, but I think the receiving physician and the receiving team will usually triage the cases to decide if the case can stay in the primary institution or whether the case has to come over. Generally, if a case is a bit more advanced and will need multidisciplinary care, for example, both the surgical oncologist, the medical oncologist, and the radiation oncologist, the case should definitely come over.
Mm-hmm. In many places, people organize, for instance, it happened many times in pediatric oncology, that if you don't have experience with managing a large number of patients, you should refer that to the center who has the facility for doing that and the experience for doing that. So this type of things sometimes are regulated, because otherwise people, patients, which is, in my opinion, the most important things here, patients are under the ideas of any specific and individual doctors who decide. And then sometimes it's important to have consensus on that. And then the multidisciplinary things is a very good tool for also for helping in that. One question that is for Dr. Pramesh is regarding the, I lost this. Without, the issue of the patients. The number of patients sometimes do not allow you to bring every patient to the multidisciplinary, or even the discussion, not physically. So there are many things that can be in that sense, and people have been asking different questions, but around the same problem. Should patients be physically or not? All the patients physically or not? All the patients discuss it or not? All the patients review it or not? So this is the question in general.
Yeah, I think this has been a repetitive question in the Q&A section as well. And I think it's dependent on the individual institution or the organization. We at Tata Memorial tend to bring every patient in, not just for the sake of making the right decision for that patient, but because we are a teaching institution, we have a large number of trainees. We have approximately 600 trainees in oncology at any given point of time. For them to understand what the nuances of decision-making are, we do get everyone. But for a more time-strapped, resource-strapped situation, I would strongly suggest that only the complex clinical situations get discussed, because otherwise you are allowing the perfect to be the enemy of the good. The second question about whether the patient needs to be there at the MDT. Again, at our institution, we get the patient in as part of the MDT along with the family member. To us, it helps us in two ways. One, very often you make certain decisions, especially in complex situations like thoracic surgery or hepatobiliary surgery. Getting a feel for how fit the patient is very important when you're taking a decision on a very major surgery. And the second reason is that it makes the patient and the family member feel a little more involved in the decision making. And though we don't explain the entire process to them at that point, because we are strapped for time, when they're called back in to explain the process. They seem to understand the decision-making process better, and they are far more willing to comply with the treatment that's been suggested. So I think there's benefit to it. It does increase the time that it takes to go through your MDT, but it's again a balance of time versus what is feasible.
Glad to hear that. I also remember the first time I was in Seattle. I was so shocked because I used to, it was in the early 90s, and we were used to see every patient and to do examining of every patient in the MDT. Then I was surprised that they only have the files of the patients and they discuss the cases. Some of the cases was just presented quickly and some of the cases were discussed. And then they invite to come to bring the patient just in case, as you said, that the decision is to take the decision, they need to see the patient really to decide if it's possible or not to do this type of thing. I was surprised, and then I learned in Seattle, I never forget that yes, you cannot see every patient in the place. You only have to discuss with the team. Thank you very much. There is another question that is for Dr. Borras and myself. That's the way that they ask the question. It is about the evaluation. How will we objectively measure success of the CCAM project? It's now not multidisciplinary team. At the end of the year 2025, in a country where is virtually no audits, no cancer registry for survival, quality assurance, well, those things. So if you have these things, of course, I will say something, and then I will let you speak, and then I will say another thing. This is talking about multidisciplinary approach. This is not a CCAN project discussion. We have what is called monitoring evaluation that has been developed, and we will find a way to do it the best we can, by sure. But this is about MDT in the center. Borras, please.
Well, obviously it's a difficult question because it's not so easy to talk about evaluation in any case, but especially in this case, because I think we should be commensurate between the program, so what we're trying to promote, and our objectives for evaluation. So I think, for instance, to demonstrate improvement in survival simply takes time, independently of it's possible or not. So I think from my perspective, this kind of projects should be measured by the things that they implement, if they are able to be sustained along the time, and the process, let's say the process indicators, more than outcomes. And the outcomes, I think it takes time. It should be part of the ideas of the process to set the measures and to set the tools to measure some, let's say, long-term impact. But I will more focus on what we are doing, if it's implemented, if it's sustained, and if it works, and not so worried about long-term outcomes that are difficult to measure in any case.
Yes, in the case of the MDT, not MDT, multidisciplinary approach, I think that even if we don't have any other tools, if the information system, of course, if we have a strong information system, if we have a strong cancer registry, of course it will make it easy, but it doesn't prevent to do things. We have to do things, because when I start to do it, maybe I'm too old. When I start to practice oncology, we didn't have all these systems. We had that only pencils and paper. And we had a lot of information that we use every year. We have been evaluating everything that we do in the multidisciplinary team. So answering also one question that was, what about the low and middle income country? If we have evidence for low and middle income country? No, like most of the things in oncology or in cancer care, most of the evidence, sorry to say, I am very sorry to say that, but I have to admit, is from high income countries. And what is the end? That low and middle income countries cannot implement like that because they have no other resources. So of course, evidence product of the research is very much needed in low and middle income countries. And I think that CCAN is trying to push for that too. We have no chance for more questions. I think that Aun is already looking at me. I think that the time is over, but I think that we will collect all the questions and we will ask our speakers that kindly respond that question later on. Thank you very much. I want to announce the first two sessions because I think that is very important. Multidisciplinary approach, you have been listening, most of the speakers has been referring also to guidelines, to appropriate guidelines, to resource appropriate guidelines, to very well-defined treatment decisions. The next two sessions are going to be about guidelines, in breast and in cervical cancer guidelines. So you are invited.
Thank you so much, Rolando. Thank you so much for all the speakers and attendees for their questions, answer, and then thank you for the very interactive discussions and participation. I would like to thanks to our speaker, Dr. Joseph, Dr. Simon, Dr. Pramesh, and Dr. William for very interesting and valuable presentation. And thank you so much, Dr. Rolando, for the moderating the session. Allow me to share my screen. We'll be following with you the next couple of weeks to provide about this executive summary of the report for this discussion and question. And if you have any questions for the feedback, please do not hesitate to get in touch with me at my email address where I've been sending out to you for all the invitation and as well as for the panelists invitation. I hope that you will be able to make the next session on the 23rd of August, where we will be focusing on the development of the resource-appropriate guideline for the management of patients with the invasive breast cancer. Please make sure to register if you are interested, and please also share the event with your colleagues and peers in your institution. So have a wonderful weekend, and then looking forward to see you on next session. Thank you so much.
Thank you. Thanks for the pleasure and privilege.
Thank you. Bye.
Bye.
Thank you.
Thank you. Bye.
Thank you very much.
Bye.